Hello, and welcome to the on-demand offering, Optimizing PrEP Access Through Advocacy. This is a recording of a live webcast that was held on April 27th, 2022. You must complete the pre-test before viewing the recording. This is available at healthhiv.org and also may be linked in the promotional emailer that you received. You also can access related content and download the presentation at Health HIV's website, as well as find the link to complete the post-test and evaluation after viewing this recording. This activity is jointly provided by the Global Education Group and Integritas Communications and is supported by an educational grant from Gilead Sciences. The Global Education Group is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. Global Education Group designates this continuing education activity for 1.0 contact hours of the Accreditation Council for Pharmacy Education. For more information about the accreditation of this program, please contact Global Education Group at the information on this screen. If you are seeking credit for activity, you must complete the pre-test, view the full recording, pass the post-test with a 70% or better, and submit a completed evaluation form. You can visit healthhiv.org or review the promotional email that you received for this activity to find the links to all of these forms. Then the CE credits will be uploaded to CPE Monitor within 30 days. No conflicts of interest among the planners or managers here, and here's information on the disclosure of unlabeled use, etc. So today, our webcast, we're looking to accomplish 3 learning objectives. Following this session, you should be able to describe how medication therapy management, or MTM protocols, impact prescription drug coverage policies, PrEP access, and health equity. Describe the basics of the drug utilization review process and its relationship to an impact on public and private insurance models, and discuss how PrEP providers, practitioners, and advocates can participate in effective MTM protocols. Our speakers today are here on the screen. We are being joined by Dr. Melissa Badowski, who is a clinical associate professor at the University of Illinois at Chicago College of Pharmacy. That is where she currently practices, and she manages patients as well with HIV in the Illinois Department of Corrections through telemedicine services. She also practices at the university's infectious disease clinic, and her specialties and research interests include HIV infectious diseases and viral hepatitis. We're also joined by our second speaker today, Scott Bertani, who is the Director of Advocacy at Health HIV. He's worked in the field of HIV and communicable diseases for over 20 years and has worked previously as a Director of Policy and Community Relations for Lifelong AIDS Alliance, served as a Washington State's Community Co-Chair to the HIV Planning Steering Group, has served in Seattle's Ryan White Planning Council, and worked in a number of other advocacy efforts, such as supporting Washington's End AIDS Plan, its Hep C-Free Washington Plan, and was the community lead on passing the Department of Health Agency's legislative package on modernizing STD laws. So a great amount of work and experience that our faculty speakers have today. So without further ado, I'm going to turn it over to our first speaker, Scott Bertani, to talk about utilization management and medication therapy management for patients at risk of HIV.
Hey, thank you, Marissa, and greetings from Health HIV as well, and good morning or good afternoon, good evening, or just plain good old day to you, wherever and whenever you're at. Okay, next slide. Okay, so people with HIV, we rely on medications that are known as antiretrovirals to reduce the amount of virus in our blood. And for people with HIV, adherence to antiretroviral regimens, either oral pills or injectables, can result in viral suppression to such low levels that it's undetectable by standard blood tests. And research shows that people with HIV who reach and maintain an undetectable viral load, they can't pass HIV on to their sexual partners. And reaching undetectable viral load can also prevent secondary infections and complications and improve health outcomes. In the community, we call it undetectable equals untransmissible, or U equals U. And an undetectable viral load is a key determinant of HIV transmission and is a core pillar in the HIV epidemic federal initiative. A crucial component of this goal involves adequate access, right, to healthcare, and it's specifically the antiretroviral medications. And the enactment of the Patient Protections and Affordable Care Act in 2010, it really raised hopes for millions of people without access to health coverage. But often high cost sharing requirements that are enacted by health plans, they place a financial burden on people with HIV and at risk of HIV who need ongoing access to these medications. And that's why improving access to medications like PrEP is such an important issue for the health and well-being of individuals. And barriers to care and prevention, they only heighten health disparities. So ARVs are often, important preventing HIV as well, right? Known as pre-exposure prophylaxis, PrEP is a pill or an injectable to prevent people from acquiring HIV. And it's highly effective when taken as prescribed, and it reduces the risks of infections by upwards of 99%. It's safe, it's clinically effective, and it's well tolerated. And most insurance plans, public and private, cover PrEP. And I say most because there are some caveats that we'll discuss. But PrEP works for women, men, people of transgender, people of all gender identities and sexual orientations, youth, and people who inject drugs. And although the specific agents for populations may vary, PrEP is pretty much an alternative prevention strategy for reducing future risk of transmission in individuals who have been prescribed post-exposure prophylaxis, or PrEP. So at its core, antiretrovirals are highly effective at treating and preventing HIV and reducing the risk of acquiring HIV. And it's critical to ensure that it's easy to obtain, and once a person is taking ART, they have to continue to have uninterrupted access to it. However, there's often barriers to accessing this needed care, including navigating a complex health insurance and a payer landscape. In the patient world, just because we've created pathways for optimizing PrEP or health, that doesn't always translate into the real-world availability and ease of use, let alone the sustained and ongoing retention, health, and wellness services that we really need to end the HIV epidemic. As such, people with HIV, those at risk, and their advocates, they need to know about some issues that are related to utilization management, or UM. And as you see in the last bullet point here, steps have been taken by HHS, the CDC, and the United States Preventative Services Task Force, or USPSTF, to make PrEP not just accessible, but available as an essential health benefit for all preventative items and services related to PrEP, including supportive services like lab, copays, and more. Next slide. Okay, so what is utilization management, and what is it as it is related to HIV PrEP? So utilization management is essentially a review of services like treatments or medications on a formulary to ensure that they really are medically necessary, that they're provided in the most suitable care setting, and at or above quality standards. And UM basically can be viewed through the lens of both a quantitative and a qualitative review process. With respect to quantitative aspects, routinely compiled drug statistics on drug utilization data that are a result of these clinical comparator health impact analysis studies are ostensibly used to estimate drug utilization management patterns across populations, by age, sex, social class, morbidity, and often other characteristics. And it's to identify other areas of potential over or underutilization. This quantitative data is also used for calculations on adverse drug reactions, right? So data is used to mine and monitor utilization of specific therapeutic classes or specialty drugs like HIV antivirals. They monitor the effects of informational and regulatory activities by law and they're used extensively in public and private health plans to estimate drug expenditures over the course of a calendar's formulary year. Qualitative studies, on the other hand, well, they assess the appropriateness or the inappropriateness or medical necessity of the utilization management, or UM, and that's relative to the underlying rationale for the decision. So the real difference between the two, qualitative and quantitative, is this appropriateness notion. And rather than expand access to an open formulary for specialty meds, UM is often used to hone in on those costs through a selection of predetermined criteria as listed here on the slides. So the real difference between the two is this notion of medical appropriateness, or in the case of the USPSTF PrEP recommendations on question 3, PrEP inappropriateness for the use of UM. And rather than expand access to an open formulary, again, it's used to hone in on those costs. But most UM decisions are often made by pharmacy benefit managers, or PBM, but they can be made by payers as well. And PBMs are companies that manage prescription drug benefits on behalf of a payer. And by negotiating with drug manufacturers and pharmacies to control spendings, PBMs play a key role in determining drug costs for payers and patients' access to medications. UM can limit access to certain drugs and treatments, regardless of whether or not your doctor has prescribed them. For people wanting to be on PrEP or on HIV treatment, this may mean they don't have access to a specific brand or generic that they prefer. And UM reflects the complexities of the healthcare system. It's the strategy used by healthcare payers and insurance companies, Medicaid and Medicare, to determine whether a patient needs healthcare services or products and procedures, including medications. In making these decisions, health payers consider often medical necessity, right? Is the treatment needed? Its appropriateness? Is the right treatment for the condition and the patient? And its effectiveness or efficiency, the use of healthcare services, right? Does the treatment actually work? For example, let's say if you need a healthcare service, such as seeing a dermatologist for a rash, you might be required to go into your primary care provider for a referral. But depending on your healthcare plan, this may require a copay that costs you out-of-pocket money. And even with a referral from your doctor, your payer may deny your request for the service. Ultimately, access to needed medications and treatments may be delayed or not even happen at all due to these barriers. So with HIV PrEP, the tables are a bit turned. So UM programs are also an essential part of a provider's organization's revenue cycle. It's intended to prevent unnecessary costs and claim denials and incentives tiering and preferred access to therapeutics and treatments, especially those most costly. Okay, so let's look at some common UM strategies that are used by payers. And one is prior authorization. You've probably come across this. This is where individuals need to gain approval from a payer before a patient can fill a prescription or receive a service. You might have often heard of step therapy. And step therapy means that patients must actually fail a less costly treatment option. That is, their condition doesn't improve, before the payer will allow the patient to access a costlier medication. Then you might have heard of non-medical switching, and that's a payer's formulary, a list of the drugs that the payer is going to cover, and changes in a way that forces a patient to switch from the prescribed medication to a different preferred therapy. You may have often heard quantity limits. Some drugs have quantity limits for prescription refills or dosage amounts over a specific period of time, which encourage appropriate usage as means to better ensure effectiveness and reduce costs. And then you might have heard of mandatory generic switching, and that's when payers are only going to reimburse plans the cost of your prescription drug that's up to the price of the lowest paid alternative medication. And these do apply to PrEP in lots of settings. Next slide. Okay, so let's briefly go over what MTM is. So medication therapy management, or MTM, it's a distinct service or group of services that is provided by healthcare providers, including pharmacists, to ensure the best therapeutic outcomes for their patients. And MTM really is a systematic process of collecting patient-identifiable information in efforts to assess a patient's medication therapy so they can identify medication-related problems, that notion of polypharmacy. And then developing a prioritized list of medication-related problems or issues, and then creating a plan to resolve them. So at its core, those are the 5 actionable elements, right? You have to have a medication therapy review, a medication record, an action plan, an intervention or referral, and clearly some documentation and some follow-up. And there's a link here for some best practices that you can go take a look at the CDC. So historically, the effect of pharmacy services for HIV-infected persons, it's been demonstrated in inpatient and clinic-based settings, right? And it's clearly something within the pharmacist's scope of work as a valued interdisciplinary team member and community health partner. But developing similar MTM programs that are adapted for community pharmacies, they really could be a model of care to improve patient adherence to PrEP therapy and retain them in care and help them regularly monitor their HIV status, their STI needs, drug interruptions or adverse drug events, and adherence again. And these briefly here, of course, they really form the backbone of successful medication management of PrEP. Support for these services really can be provided to HIV infected patients and at risk through pharmacist-managed PrEP MTM programs in community pharmacy settings. That is in particular collaboration with primary providers and often healthcare professionals. And they help reach the patient's ultimate health outcome goals. Here it's to avert an HIV infection. So really, community pharmacists can really help meet the growing need for HIV care through the provision of MTM services. But while the general framework of MTM has been around since 2003 and 2008, when 11 national pharmacy organizations conceived this notion, there's still a lot of challenges of adequate training, education, and support of community pharmacists that clearly need to be addressed in order for PrEP MTM to be a successful, scalable model. And MTM can actually help keep in check by navigating patients to the appropriate referrals and resources, even to know which PrEP to dispense based on the patient's health plans. And that can be complex and challenging, especially if there's prior authorizations or mandatory generic switching that's required. It can also be administratively time-intensive. Next slide. Okay, so there are approximately 60,000, 67,000 retail pharmacies in the U.S. And to that, you, the pharmacist and provider and health navigator, through this extensive network, you can help bring the U.S. closer to ending the HIV epidemic. And historically, pharmacists have been able to order testing and prescribe medications under 2 things, right? Collective practice agreements, collaborative practice agreements, or CPAs. And that's what at the heart of it is basically just a formal agreement with a licensed provider who makes a diagnosis, supervises the patient cares, and refers patients on to you, the pharmacist, under a protocol that allows you to perform specific patient care functions. And right now there's about 4 to 5 state statutes that permit prescribing for pharmacists in order of appearance. It's California, Oregon, Colorado, Missouri. And that gives you all the legal authority to prescribe and dispense PrEP independently. That's big news. And in many states, laws are being proposed to enhance a pharmacist's ability to prescribe, like in Utah. And this ability to prescribe and dispense is exactly what expanded access should look like in the real world. But the real world is really fraught with complexities around costlier specialty medications like HIV treatment and PrEP, each of which are antivirals. And antivirals are the agent, PrEP is the intervention, and they're classified that way. But effective medication therapy management is meant to enhance access and utilization, not just look at the cost drivers to restrict or limit access to medications. So after some really long years, 12 of them now, where PrEP has kind of languished in community uptake because of the complexity of and cost drivers, the community began to take HHS, the Department of Labor and Treasury, to task, and it was through the USPSTF, that that good results really have come forward to make PrEP items and supportive services accessible and available at zero cost for most health non-grandfathered plans. Next slide. So to support implementation of the CDC practice guidelines on PrEP, the task force created their own recommendations and efforts to facilitate meaningful discussions between clinicians and their patients, and they gave PrEP as an intervention a grade A recommendation. And a grade A is conclusive evidence that PrEP is of substantial benefit in decreasing the risk of infection in persons at high risk. And it's also found convincing evidence that adherence to PrEP is decidedly associated with its efficacy and in its preventing HIV infection. So it pretty much ensured that adherence and supportive services to PrEP are central tenets to HIV health outcomes, and pharmacists can play a key role. And I would encourage our clinicians here to pore over these guidelines for reference clearly, but also as a basic conversation starter to help encourage patients that might be good candidates for PrEP. And at the end of the presentation here, we'll list some resources where you can find some really good stuff. But we'll briefly highlight the recent recommendations on PrEP and why they matter to this discussion on So as part of the FAQs, or frequently asked questions, that were released in July 2021, the USPSTF specified that plans and insurers may use reasonable management techniques, or to the extent that the USPSTF recommendation doesn't specify the frequency, the method, the treatment, or the setting for the provision of PrEP services. And let me pause right there and say that again, in case there were any post-test questions related to that part. So when may a plan or issuer use reasonable medical management techniques with respect to coverage of PrEP? Plans and issuers may use reasonable medical management techniques to the extent the USPSTF recommendation and guidelines doesn't specify the frequency, the method, the treatment, or the setting of the provision of PrEP services, if those requirements are not specified in the recommendations. But the CDC recommendation states that the frequency of HIV PrEP testing, in effect, can only be used if there are exceptions to policies in place. And plan policy is commonly referred to as prior authorizations, or step therapy, or fail first, that non-medical switching, quantity limits, and mandatory generic switching. Exception to those policies must be in place if plans choose to use However, plans and issuers can use reasonable management medical techniques to instead encourage individuals prescribed PrEP to use specific items and services to the extent that the frequency, the method, and the treatment is not specified in the recommendation. So, without an exception to policy, you can't deny someone PrEP, but you can restrict the types of PrEP agents relative to its medical inappropriateness. That means that plans and issuers must accommodate any individual for whom a particular PrEP medication, generic or brand name, would be medically inappropriate, as determined by the individual's healthcare provider. So in this regard, the FAQs, and there's only 3 of them, they advise that it would not be reasonable to restrict the number of times the individual may start HIV PrEP, since the recommendation itself really does specify the provisions of services. And the final recommendation statement for PrEP confirms that HIV testing is needed every 3 months while taking PrEP, or is frequent, and you can't be charged for testing. The same applies to other aspects of those services with respect to office visits. And office visits associated with PrEP-related preventative services have got to be covered without cost sharing when the preventative services isn't billed separately from the office visit. So if my appointment is indeed for the preventative service being billed and it's not coded separately as a diagnostic versus preventative service, for example, then that visit must be covered without cost sharing. However, what we're hearing is that some people who are being charged with these visits or follow-ups are that they're coded incorrectly in the ICD-10 procedure coding system. And that could be part of the implementation problems with the FAQs at some insurers. And we have a list of that on the resources. Next slide. So let me review this slide in its short context, because I know that Melissa is going to be talking about this as well. So how applies to PrEP means that most health plans, except for grandfathered plans, they must cover the full cost of the PrEP medication without cost sharing. That translates into no copays, no coinsurance, or pharmacy and medical deductibles. That uptake has been challenging, and is partly, if not mostly, to blame, because plans have made it challenging for people with health inequities and disparities to get on and be retained on PrEP, and none more concerning than those with social determinants of health circumstances. In fact, PrEP expansion opportunities need to be coupled with structural and sustainable interventions to address vulnerability to HIV infection among Black and Brown communities, women and trans women, and clearly MSM. So effective MTM for PrEP by pharmacists really should aim to enhance utilization through medication adherence counseling, as supportive services, and lots of identification of gaps in patient prevention and care services. Next slide. So listed here are some of the common MTM issues. Ineffective MTM or policies, they can delay not just the start of PrEP, but its ongoing use. It can cause higher walkaway rates from pharmacy counters. It can cause missed doses if all of a sudden a plan or a person is on chooses to use to restrict brand names, if in fact that's what the patient prescriber decided on because of its medical inappropriateness. So they may still have to jump through hoops on prior authorizations, and those are not walk in the parks. Those are time insensitive. So it can be increased with pill burden, breaking the med into its component parts rather than co-formulated meds, right? Single tablet regimens versus multi-tablet regimens. And ultimately, this always reduces health equity. Next slide. So I want to talk a little bit about advocacy, right? So clearly patient utilization on is one advocacy opportunity, but advocacy looks differently relative to how you're onboarded into the PrEP system. Whether you have Medicare or Medicaid or employer-sponsored plans, all plans look at through a different lens. Some focus on cost alone, while others look at the qualitative aspect of health, the health impact analysis, right? So every Medicare prescription drug plan, a PDP or an MAPD, and Medicaid across all 50 states follow a different philosophy when it comes to drug usage management. While is often required, drug utilization review, or DUR, another acronym like DURs are often just simply boards or committees comprised of providers that pore over the qualitative and quantitative metrics of a drug formulary, and they may choose to limit their formularies or enact restrictive MTM protocols for patients with complex health needs or high utilization patterns. And the DUR is basically just an authorized and structured ongoing review of practitioner prescribing, pharmacist dispensing, and patient use of medications. And the purpose of the DUR, at its core was meant to ensure that drugs are used appropriately, safely, and effectively to prove health status, but they're often insidiously meant to restrict clinical comparators that are just as efficacious, that may cost more, or get this, don't have the same rebate dollars associated with it. Next slide. So since Melissa is going to touch base on the health impacts of or DUR boards on HIV PrEP, I want to highlight, here on this slide, because really can lead to delays in appropriate PrEP treatment and HIV treatment. And these measures really result in actual disease if they are seen as too burdensome. Remember, and listen again, so if plans and issuers are utilizing reasonable medical management techniques, they must have an easily accessible, transparent, and sufficiently expedient exception process that's not unduly burdensome on the individual or provider. So the PA or the exception to policy, it's got to be easy. If not, delays in beginning treatment may threaten our health. It's disrupted or delayed access to appropriate treatment that has other potential consequences, just beyond physical wellness. The mental health burden of being on a medication with uncomfortable side effects that can really negatively impact the patient's self-image and make it more difficult for them to stay adherent. Next slide. And that brings us again to MTM advocacy. So remember, while UN is meant to make things cost efficient, and they do offer value-based care, in some respects it can be a shell game to where plans restrict costly specialty medications like HIV PrEP. And while MTM is a well-intentioned concept developed by for-profit organizations, so patient protections aren't always their first deciding factor. And qualitative health impacts are often seen as less prioritized over quantitative cost considerations. Next slide. All right, so what can you do about all of this HIV PrEP, and why does the pharmacist really need to know about this? Well, because not only do you play an integral part in your patient's health, but as clinicians and prescribers, friends, and advocates for ending the HIV epidemic, you can help influence what DERs, or drug utilization review boards or committees, decide what goes into a plan or issuer's formulary. It's not easy, but it can be done. And now more than ever, as we plod towards some national formulary, you can be a patient advocate to educate your patient on formulary plan design and prescription drug access coverage and how it affects access to effective treatment. You can also talk with your state and federal insurance regulators, your marketplace officials, and state lawmakers, and help call out and define discriminatory plan design and discriminatory UN rescissions, and identify specific examples of these discriminatory benefits designs and bring them. And you can work with your state's Office of Insurance Commissioner, or OIC, to educate their office and their consumers about the recommendations or the FAQs and zero cost sharings for items and services. Heck, you can also work, to serve on a Medicaid Provider and Therapeutics Committee in your state's healthcare authorities' oversight of their Medicaid plans. In fact, in Washington State, we did exactly that, and through patient advocacy groups and the aligned HIV community, we moved the state from a fail twice policy in July 2017 to a fail once but with broader exceptions to UN policy. And we weren't done there. Then we advocated to get the LGBTQ Commission at the state agency level to start a medication access group that was public stakeholder input to review these discriminatory access restricting practices. And Governor Inslee then signed a budget proviso to carve out HIV meds and actually see what open access would really cost. And it's a bit complicated, but it's really doable. And it begins, one, with just seeking out your state's P&T committee, that Providers and Therapeutics Committee, and how they determine state formularies. You can also help patients get on or find drug coupon and patient assistance programs, or ensure patients are aware of what copay accumulator programs are. And in a copay accumulator program, they change the way an insurance company applies and accounts for payments from a drug manufacturer's copay card. So ultimately, there are many, many things that you can do to help the process along. And we would be happy to begin those conversations and those coalitions. So I've included my email at the front so that we can talk a little bit more about what advocacy may look like. And on the next slide, one more slide. Here are some of those really good resources, right? We can talk about ending the HIV epidemic there. And we can look at Please Prep Me. And here on Please Prep Me are lots of toolkits that you can see, like ICD-10 codes that are preventative and diagnostic codes for all of HIV services. There's also lots of the links to the conversations that I had. And ultimately, you can also do something simple like do the HIV PCP certification program that has lots of modules that you see here, and we run that accreditation. Now to turn this over to Melissa.
All right, thank you so much, Scott, and thank you to everyone for joining us today. It's hard to believe that we are coming up on the 10th anniversary of approval of tenofovir disoproxil fumarate with emtricitabine, also known as the original PrEP. And so that comes in about July of 2012 is when that 10-year birthday will be. So very hard to believe it's been 10 years, but what remains is that about every 14 minutes, so over this call, another 4 people will be diagnosed with HIV, meaning that these efforts in PrEP and treatment as prevention and U equals U, we still have a long way to go to eliminate HIV. So while many people and adolescents qualify for PrEP and have indication, those at highest risk for acquiring HIV are still not accessing it appropriately, or they maybe don't necessarily know where to access it. And so this is really, where we're all coming together today. It could be within the community. It could be in different clinics of where just identifying those who are eligible. And so in my mindset, I put a pretty low bar, and I say anyone who's having sex, anyone who deems themselves at risk, anyone who's injecting drugs may be at risk for acquiring HIV infection. And then we have to further look at who are their partners, what are their practices, do they have an STI that was recently diagnosed? And if any of those questions are yes, or answers to those questions are yes, then we really want to have those conversations with the patients. We really want to identify those that are at risk, and we'll do that in a little bit. Some of the other populations that maybe aren't really hitting the mark on getting PrEP access. Additionally, we definitely need to make sure there are testing that is available to us. So has there been a recent HIV test that's negative? And in order to have PrEP prescribed, it's within 7 days. And this is, within both the oral and intramuscular options that I'll go through. But then also we need to look at kidney function, especially for those who are taking oral PrEP options. If they're on a TAF-based therapy, so tenofovir alafenamide with emtricitabine, creatinine clearance has to be greater than 30 mils per minute. If they're on a TDF-based therapy, it has to be greater than 60 mils per minute. And the other thing, of course, as pharmacists, we always think about are what are the drug-drug interactions. And so we want to make sure that people are accessing these medications without anything that could reduce how well they work. So certain medications like anti-seizure medications can definitely interact with TAF-based therapy as well as intramuscular therapies with Cabotegravir, so some of them like carbamazepine, phenytoin, or our rifamycins if somebody's being treated for latent TB or active TB infection. So we don't want them to fail because we don't want to then put them at risk for acquiring HIV. So we want to make sure that we're definitely looking at everything, for each person and on an individual basis in that regard. So when we think about our daily oral PrEP options, we have 2 options that are available. TDF-based therapy, so your tenofovir disoproxil fumarate, is available as both brand and now a generic formulation, which can further expand access and reduce costs for patients. It is also approved as on-demand or 2-1-1 therapy, where people who deem themselves at a higher risk can take 2 tablets of TDF-based therapy 2 to 24 hours before they end up having an encounter, a sexual encounter. And this was studied in men who have sex population, followed by a pill 24 hours after their first dose, and then another pill 24 hours after that second dose. Of note, TAF-based therapy has not been studied in this way yet, so this is only approved for tenofovir disoproxil fumarate-based therapy. The other thing is that it can only be given for a 90-day supply. So we have a lot of pushback from our patients. Why are you making me come in every 90 days when if I had HIV infection, I would maybe only have to come in every few months, like every 6 months or so if I'm doing well. But that's really, again, to make sure that they did not seroconvert in that amount of time. They have a recent HIV lab work that's showing they're negative, and they don't have any signs and symptoms of infection. So I know it kind of gets murky with the COVID pandemic. Some of those signs may be similar, but then if they have night sweats or increased lymph node size, that's something we also have to think about. When we look at cabotegravir-based therapy, so the PrEP guidelines at the beginning of December of 2021 were updated, and at the end of 2021 in December is when cabotegravir came to be FDA approved in the U.S. So I'm really glad that the PrEP guidelines were able to incorporate this in even before the approval, because now we don't have to wait another 5 or so years to incorporate this into practice. And so this will give a lot of freedom for patients who maybe are not interested in the option of taking one pill once a day. But again, what Scott had mentioned is that some of these insurance companies are not necessarily going to pay for this modality, unfortunately, until maybe somebody fails or they're having difficulties with taking oral PrEP options. So when we do initiate, and if an insurance plan is able to do intramuscular cabotegravir, it's dosed for the first time, then given a month later, and then is when we can get on the Q2-month dosing schematic of that. Of course, we have to think about missed doses, or if they're unable to access healthcare or be transported over to receive their dosing. So there are some, pros and cons that you can see with both options. So we've likely seen the benefit of PrEP, and this is based on our continued reduction of HIV incidence, where between 2015 and 2019, the incidence of HIV was reduced by about 8%. So we definitely still have ways to go, especially if you look at ending the HIV epidemic. And our goal is to have only 3,000 new infections by the year 2030. We're still about 10 times higher right now of where 2030 goals are. And then we also look at basic preliminary data from the CDC. And on the right-hand side in your blue box on this chart, 2020 was a better year for PrEP prescriptions or access, where 25% of the 1.2 million people for whom PrEP would have been indicated for was prescribed it, compared to 2015, which is in green, and there's only 3%. So the uptake is definitely increasing. We're slowly making strides, I would like to say. But in terms of ending the HIV epidemic, by 2030, the goal is to have 50% of people on PrEP for whom it is indicated. So we are making great strides. We do have some ways to go. But there are other mechanisms for reducing HIV transmission. And this could be from improved testing, because we still have 13% of people who are unaware of their HIV status and can be transmitting it. Also, as Scott mentioned, was the U=U movement, also referred to in the past as treatment as prevention, where if you have an undetectable load, you are virtually unlikely to transmit HIV infection. And so, as you can see from the statistics here, we have a ways to go with engaging, retaining patients into care, but virologic suppression-wise, we only have a little over 50% of the people who are diagnosed with HIV actively virologically suppressed. So we still have a large population that we need to offer PrEP to, we need to have more testing, and we need to really get that message about U=U out there. And so when we look at more recent data from 2019 to 2021, and this was, obviously we had a huge pandemic that came into the mix of things, we were on the way of increasing those numbers of who was using PrEP. So if you can see by the vertical yellow boxes for that PrEP coverage is calculated as the number of those who were prescribed PrEP divided by the number of people who had an indication for PrEP. Clearly, we are way off with this. In 2019, there was just a little over 20%, but now that has dipped down to 2021 to merely 16%. And as you can see, there's specific age ranges that aren't hitting the mark. specific ethnicities, and genders. So these are really where a lot of these interventions need to start to take place. So I'd like to spend the next part of this presentation looking for those who are missing being offered PrEP and the uptake. Again, based off of the CDC data from 2020, we see that Black and African American, as well as Hispanic and Latino populations, are at a huge disadvantage, although these populations account for the majority of people for whom PrEP is indicated. When we think about those who we really need to make sure that we're reaching, really I advocate for the adolescents and young adults, because if you're an adolescent, you may still fall under your parents' insurance plans. You're afraid that they might find out that you're having sex or engaging in different behaviors. And so this is really where we need to start to focus attention. For those ages that are 16 to 24, they were the least likely to be prescribed PrEP. Only about 16% in 2020 received that from that population. Again, there's a huge gender gap. 10% of women were accessing PrEP compared to 28%. So these are not great numbers by any stretch of the imagination. But now, just think if you are a Black woman trying to access PrEP, you know, as we had seen from the other slides, they're not accessing it or having offers to it as well, or the uptake isn't there. So we really need to start to increase, you know, that messaging as well. Another population near and dear to my heart, as you had heard, I work within the Illinois Department of Corrections, where we provide HIV care throughout the state of Illinois. So prisons on a whole are unlikely to allow for condom distribution, let alone PrEP. And so PrEP may be likely within some jails, especially if there's a short-term stay prior to sentencing. But again, we still have so much room to grow in this arena, and the correctional population does have a high incidence of HIV, as you know we tend to see. There's other modalities for active substance use, and so if there's maybe Suboxone clinics, methadone clinics, or maybe those with mental health issues, going into those clinics to start to provide PrEP consideration is definitely needed. I know some are doing great work there and identifying patients within these populations, but again, there's so much more to go from this standpoint. Also, for those who are testing positive for a sexually transmitted infection, automatically PrEP should be you know, offered. And I know within our population, we go to offer it, and people are looking at us, well, why would I want that? And we're like, well, you just tested positive for gonorrhea, chlamydia, you name it. And so they're often taken aback, and sometimes they need to think about, you know, being offered it and taking that help a little bit more. And then ultimately, and this is where we all fit into, collaboratively, all clinics should be incorporating this into their workflow. Within community settings, this should be in the workflow. Again, I know resources are so limited, and it would take additional planning to implement this. But again, I think the need is just so great there. Additionally, student health clinics, again, tapping into that adolescent and young adult, you know, from maybe college campuses is really needed. But again, it shouldn't be the people who are referred to ID. It shouldn't be in these sexual health clinics. It should be from primary care providers. It should be, you know, from family medicine clinics or student health clinics, that we're just routinely offering PrEP to these individuals. So when we start to think about expanding our reach in a collaborative manner, pharmacists are the most accessible profession. On average, people come to pharmacies 35 times a year. Other statistics, you know, more than 90% of people live within 5 miles of a pharmacy. They're open 7 days a week. They have extended hours. Sometimes it's 24 hours. So there's just so many reasons to incorporate pharmacists into these models, especially with the oral PrEP or post-exposure prophylaxis if somebody did have an exposure within those first 72 hours. So we've listed, you know, those areas that have legislature already approved for this. I know within the last month, Illinois was added to this list. But then there's also, from the standpoint of pharmacist-run protocols, and I know that's something that we do within my system is that, within our clinics, we're able to manage pre-exposure prophylaxis in collaboration with our providers. So just any way that we can reduce the burden, or maybe provide the time and energy to talk to these patients is definitely needed. We've already discussed some of the insurance considerations and that lack of standardization among the public and private payers, but I think it's still important to bring that up. There's also the discussion about prior authorization. And I cannot tell you that how many people will not access the medication because they don't understand what a prior authorization is. They feel like they've been turned away from a pharmacy. They're too embarrassed to ask what that actually means. They just know that they can't get this medication that was prescribed. And sometimes they're afraid to ask questions. Sometimes they're embarrassed if there is a copay that is associated with it and they can't afford it. So, when I think about a lot of these issues here, I make sure that before a patient actually leaves our setting, our clinic site, that they're able to access their pre-exposure prophylaxis. Or, at the very least, I know that there's a prior authorization, and I tell them that I am going to work on that to make sure that we are able to reduce some of those burdens for the patient. Again, looking at those drug utilization review, there's various ways of looking at it, but then we start to think about, maybe the tenofovir disoproxyl fumarate compared to TAF. And then we look at maybe who would benefit from that, and especially in the adolescent population, if they're going to be on this longer term, we need to be looking at safety. And there are a few studies that are out there, but they're short-term data for maybe like 48 weeks. So I think more data is definitely needed for these populations. Again, we need to make sure we're ensuring these through medication therapy management so that we're able to have patients access PrEP, looking at quantity limits, potentially providing medication synchronization are other ways in addition to the prior authorization and identifying formulary requirements. Again, some of those challenges I've pointed out already, but there are so many amazing resources that are available in ensuring access that I do want to point these out. And so in regards of, there's the AIDS Drug Assistance Program, or ADAP. Many states, I know mine does, has something very similar that's PrEP-DAP, that you can go and apply for that if you're underinsured or you weren't able to afford those copays. And again, it has to be outside of a state or federally funded program. Just like a lot of the drug companies who do sponsor these medications or provide them, you can access patient assistance programs as well as activating copay cards. These can be activated and completed from any community pharmacy, just as well as our clinics. So there's, it's open to everyone. Patient can assist with that as well. So in terms of advocating to end the epidemic, aside from some of those resources, there is another site that's available, and I've indicated this link here, where we talk about the Ready, Set, PrEP. And so right now, this is only available for oral PrEP. Maybe in the future, it will be available for injectable. But at this point, only oral, and it's for patients or providers to be able to provide or access and sign up to see if they would qualify for this. There are a few requirements. They cannot have health insurance. They have to have a negative HIV test prior to accessing the medication, have to have a valid prescription, be a U.S. resident, and then there may be costs associated with clinic visits or lab tests, but again, that will be dependent on any income. And so this will be yet another resource, if all else fails coming up to this, that you can also encourage your patients to check out, or even for you to check out. So very low-hanging fruit if you have a patient maybe who is coming in asking about maybe sexually transmitted infection. How are you protecting yourself? And this just gets to open it up for a patient, and then maybe you complete that longer sexual history for a patient. Offering PrEP is always the way to go instead of waiting for somebody to ask for it, because a lot of people are intimidated by that process. So I just blanket offer it to a patient. If they tell me no, I have thick skin, it's okay. But the next time I see them, I'll probably ask them again. And I always tell them, don't worry, I'm probably going to ask you again. And maybe right now you're not at risk, but maybe in the future you do have a different risks category. We also want to make sure that we're trying to help navigate with some of the technology. So advocating for maybe tele-PrEP clinics as well. This allows some flexibility for people to go get their labs at a convenient time, and then maybe they don't have to come into the clinic unless they're getting an intramuscular option for PrEP. But this can reduce missed appointments, and we can help to continue having the patient take PrEP instead of causing different barriers for the patient. Again, our patients really want to take the PrEP, but they don't want to be hassled with coming back to clinic all the time, taking time off of work to see a provider, or we're just trying to make it easier for the patients if we can. So my motto is really going to be, even if I can prevent one infection, that starts the schematic to prevent future infections. So start small and scale up when we can. Here are my references for you to all reach out to if you need them. But now I know we only have a few minutes, but I'd like to open this up for questions and answers that we'll provide.
Great, thank you so much. I know we are to reaching the hour mark of our webinar, and I want to enthusiastically thank Scott and Melissa for really excellent information. We have quite a few questions in the Q&A, and I think we'll try to get to one or two of them if we have time, but I just want to let you know that we will be sharing this, certainly the questions and possibly posting an FAQ for you so that you have the ability to access some additional information later and also be able to get answers to your questions. So we'll make sure as much of that is available on the website. I think that one question that was interesting around PrEP access was barriers for minors. And I think a lot of that is related to confidentiality. And I'm just wondering if, Melissa, from your experience, if you have any recommendations for how youth, best ways to engage youth or kind of essentially navigating barriers that youth might have to accessing and getting coverage for their PrEP medication.
Yeah, so again, the youth don't necessarily know that they could have access to it, and again, it's something that we can definitely offer to them, and we can do it definitely confidentiality-wise, but again, a lot of them are afraid that it's going to show up on their parents' insurance, so we are able to offer it in the pediatric clinics. Some patients will actually come to other clinics and offer it. Again, it's going to be on a state-by-state basis what's allowed and what's available. But again, having events, especially catering to the youth community, is yet another way. And I know there's so many great events that are ongoing out there. But again, just letting them hear the message, being educated on the message, and then just asking, if they are being further, annual follow-up or any time that they're coming in, are engaging in any sexual activity? Again, that could be very uncomfortable if the parent's there, so maybe, say we're going to discuss this, or ask the parent to step out of the room at that point as well. Again, it's going to really be up to, the patient in that regard. I know within the last couple of months, we've had a lot of 18 and 19-year-olds get diagnosed with HIV and had no idea that PrEP was an option for them.
Great, thank you. So we are at the top of the next hour, and I do want to be respectful of everyone's time. Thank you so much. I'm seeing in the Q&A there's a number of questions around specifically around covering costs of PrEP. And I just want to point out to everyone that in the related content pop-up box, you will see a link to pleaseprepme.org, which is a site that Health HIV manages. And on that site, there actually are a number of resources for providers around covering the cost of PrEP. And that includes comprehensively the cost of clinic visits, lab tests, as well as medication. And Melissa highlighted some of these, and Ready Set PrEP is a great resource for covering medications as is advancing access. However, there are barriers sometimes with covering the cost of the clinic visits and the lab tests. So I just want to encourage you all to both visit healthhiv.org for more information, visit pleaseprepme.org, specifically related to covering costs and navigating costs, because that is truly, can prove to be a barrier to PrEP access. But anyone who wants PrEP can and should be able to get their costs covered. So if you have additional questions, please reach out to us at Health HIV, and we'll be posting some additional information and some responses to your questions on Health HIV's website, along with the slides and a link to the recording for the webcast today. So thank you all for attending. Thank you so much to our two speakers, and we look forward to engaging with you all again on a future webinar.
If you are seeking credit for activity, you must complete the pre-test, view the full recording, pass the post-test with a 70% or better, and submit a completed evaluation form. You can visit healthhiv.org or review the promotional email that you received for this activity to find the links to all of these forms. Then the CE credits will be uploaded to CPE Monitor within 30 days.